I'm not sure this is the U.S. perspective, but it's my perspective. Um, and we'll go over some of the data and hopefully review some of the experience worldwide. But I'd like to, as everyone's done, I'd like to start with a case that, frankly, as we discuss whether it's worth it, I'm not sure how you put a dollar amount on, so I agree with Steve. This was a young woman. She was I think 27. She had an emergency C-section for fetal distress. She left the hospital with some mild hypertension and some tachycardia and was on some beta blockers. 3 weeks later, she comes back with a short of breath, a fever, and basically respiratory distress. She gets intubated. This is one of our peripheral hospitals at the University of Pennsylvania. She gets intubated and goes to the cath lab. She arrests. She has CPR for over an hour. In the cath lab, they do what they had. They have the hammer, use what you have, and they put in an Impella 2.5, and then called us up on the phone and said, "Can we send her to you?" And we of course brought her over immediately, which this hospital's about a quarter of a mile away. She comes, when we do accept people like this, they go directly to the operating room, so there's not a question of beds availability or not. It's the best place to resuscitate, to triage, and to decide what to do because you have any tool available. This was her chest X-ray on admission. You can see the drugs she was on, and that's like a lot. She had a blood pressure, but she was purple. She was not oxygenating. She was acidotic, and the Impella was spinning around 2 liters, but her urine was black. It was hemolyzing severely. And we felt the only technique to save this 27-year-old was to place her on ECMO. We did a couple things. We exchanged the Impella for the arterial 18 cannula. We put in a 22 heart port venous into the right atrium. And then we did another thing we will occasionally do to vent the ventricle. We actually put a PA cannula in that we use for like heart port. And we were able to get an additional 600 cc's and decompress the left ventricle in that way. And in the end, we had 6 liters flow. She actually did pretty well, she was resuscitated. She woke up from her arrest. Her pulmonary edema resolved. Her chest X-ray cleared. She did develop renal failure and required a short period of dialysis. And she was not deemed at this point a heart transplant candidate, but we did use this as a bridge to HeartMate 2, again for destination at this point. Again, all the systems improved except for her kidneys, and she was eventually actually required a trach. You can see she was started on CVVHD, continuous dialysis. By 3 weeks, she started making urine. She left the ICU at 3.5 weeks, and you can see her creatinine, how it came down on VAD support. She was discharged home on day 43 from the hospital, and at the time we put the HeartMate 2 in, we did a biopsy which showed evidence of a myocarditis, and she eventually was able to be weaned to recovery, full normal heart. And that's her actually getting married on the HeartMate 2 in the hospital. This was her fiance, and the VAD team was there. It was quite a special moment for us. So what are the goals of percutaneous or temporary mechanical circulatory support at cardiogenic shock? Frankly, the first goal is not the heart, but the body, and you have to save the life. So often I think we do things not really focusing on what the real important thing at that time is, and it's to eliminate shock and in-organ function, a triage device to allow neurologic recovery. I go relatively inexpensive. In the United States, we don't even use a Centromag anymore because that's $14,000. We use a McKay pump, which I don't know if it's available here, but it's a few $100s, not even. And it actually has, I believe, at least for several weeks, as good as far as not having hemolysis and everything like that. It can be used as a very nice bridge to revascularization. as we've already seen, it limits infarct size more than a balloon by decompressing the ventricle perhaps. And again, I'm talking about all types right now. Potential recovery as a bridge-to-bridge strategy, and a nice way of terminal weaning and death. Because if you're going to do this, you're going to have your resources to know that most of your patients are still going to die. Let's say 50% or more are going to die. So is that something you're ready to do? Steve has already mentioned back, 10 years ago, we only had our durable pumps, not much temporary pumps, but you can see how things have changed and that cardiogenic shock now is not handled by durable pumps. They're too expensive for these high-risk patients that have a high risk of death. So we use inexpensive pumps. And this is a sort of way of thinking about it right now. We know that mortality increases as your inotropes increase. And once you get to 2 inotropes, half your patients are going to die in cardiogenic shock. So I believe in mechanical circulatory support. And I believe now, though I didn't 10 years ago, that with these new tools, we don't have to commit a lot of money to these really high-risk patients, but rather use short-term devices, save our conventional VADs for this group, where we're going to have the best outcomes, and send the short-term VADs, the less expensive VADs, for the areas where your mortality is going to be high, and we call that bridge to decision. So you can use these short-term devices or ECMO in any one of the etiologies of acute heart failure. We've already heard about post-cardiotomy shock, Steve, and I won't go too much into that. And they're very useful for heart transplantation and primary graft dysfunction, which has really helped in that area. And there's a variety to choose from. Well, obviously the mainstay is still the intra-aortic balloon pump because it's so easy, and because frankly I might disagree a little with Steve, but it does help you get off the heart-lung machine if used properly and in the right patients, not the sort of the dead and dying. Where is the place for the Impella? Again, my bias is that 2.5 is in the cath lab. It's not for shock. It should not ever be used for shock. We have ECMO. Tandem heart actually can provide up more like 3.5 to 4 liters perhaps. Heard a lot about the Centromag experience, and I'm not going to talk too much about these pumps since they're not used to anymore. The Thoratec PVAD was a really useful device for many years. Again, the shock trial shows that in, again, shock patients, and these are not the same shock patients you've heard earlier, but when controlled in the shock 2 trial, there's absolutely no evidence of a mortality benefit. So what is the paradigm here? So for more advanced cardiogenic shock, what's our algorithm? Many of these patients will be on a balloon pump first, they'll be on pressors, and if that suffices, take them to surgery. But often it doesn't suffice, and you have to be able to use a temporary VAD or ECMO support for recovery, for triage. Often these are undergoing CPR. We'll talk about our experience with that. And they have often, they don't wake up. And then as a bridge to a bridge for varying types of strategies, whether destination or transplant. In the work out of Pittsburgh, and I have to say that the guy who's done a lot of this is Christian Bermudez, who we've been able to recruit from Pittsburgh across state to Philadelphia, and I can't wait till he comes so I don't have to do this anymore. But there are, some work there, and I'll show you some data later, that if you have CPR that's undergoing, your results with emergent bedside ECMO for having a live patient are better less than 30 minutes than if you keep going for over 30 minutes. Obviously, perfusion breaks down. And again, it gives us time to really learn about the patient, learn about the family, the social situation. And so often we find this is a no-go, it's a non-starter. They develop horrible multi-system organ failure on ECMO from their arrest, from their shock, and we just withdraw. And the economics, I'm not going to go into in the United States or such, and you'll see the economics for ECMO in the United States for the hospital are extremely favorable because half the patients are dead and withdrawn within a day, so you don't spend a lot of money. It's just a wonderful triage device. If you use the McKay pump and a Quadrox oxygenator, you have a system that's really about a few $1,000s, and for at least right now, the reimbursement from CMS is extremely large for that. So it is actually probably the best triage device for the patient in extremis. Talked a little bit about Impella. It's 3 varieties right now: cath lab, intermediate, and now the 5.0, which I think is a good short-term shock device, and it does decompress the ventricle a lot better than ECMO. You may be familiar with this. The what the Impella will do in whatever variety, it does improve hemodynamics. It will pump more blood in a weak ventricle. It will lower your filling pressures. However, when one looks at it, there was no difference with the 2.5 versus a balloon pump as far as survival or recovery of multi-system organ failure versus AMI. So again, I don't think it should be considered, like Our Lady we had. If one looks now at further experience in Europe, mainly, the 80% being the Impella 5.0, again, there's such a selection bias in any of these trials because the patients are all different. What one person calls shock, another person might say, oh, that's just our normal patient, versus, as we heard, Intermax -1 to -2, -3. But not a bad survival. Again, you don't know what the patients are, but again, this was used in post-cardiotomy shock as well as a sort of primary ischemic events. And again, it's certainly suggestive that it does work. In my opinion, the only Impella device for shock should be the 5.0. We're doing it with a graph shown on the axillary artery, which seems stable for at least about a week. But again, I don't think you get the patients out of the, I'm sure some centers have gotten them out to a chair, but certainly not walking around. The tandem heart, as you all know, is transeptal. A lot of experience with that. In the best series is actually from Texas Heart, and I don't know how they did this, but in over 100 patients, both with ischemic cardiomyopathy and non-ischemic cardiomyopathy, and I can tell you, talking to Igor, half these patients were having active CPR. They were actually taken from the floor to the cath lab, where those guys are 27 in the cath lab were able to put a transeptal cannula in, which I think is a pretty unbelievable approach. I think it could never work at Penn, and I don't think it can work at many centers, but with this they were able to basically get a 50% survival with the tandem in a very sick population. In a sort of meta-analysis that Dan Burkock did, looking at both tandem and Impella, there's no question compared to a balloon pump there's an immediate hemodynamic benefit, and there's also no question, at least at this early stage, there was no survival benefit in this meta-analysis. What I'm most excited about with these two technologies is not their LV support, but rather what's coming down the pike for the right ventricle. There is an ongoing randomized clinical trial with the Impella that is actually turned around. So it's advanced through the groin, or I think, or from the IJ into the PA, and it can, for the right heart, so often in coming off bypass for the right heart is why we fail. Not so much left ventricular dysfunction. And I think if you could supply 2 liters without having high-dose epinephrine and all the other drugs, I think that might make a big difference. We're obtaining the tandem heart, which is basically a dual lumen cannula through the IJ that can be, again, advanced, similar to the Avalon that's used sometimes for ECMO. And I'm very excited. Again, the Pittsburgh experience now has done this several times for post-cardiotomy RV failure or RV failure after an LVAD or a heart transplant. And again, 2 to 3 liters, not having to leave the OR on high-dose inotropes, high-dose pressors, so you don't develop multi-system organ failure. Your CVP is low, your perfusion pressure is higher, you don't have that liver failure that we're so troubled with right now in our high-risk, long bypass cases. Again, the Centromag, you guys have a lot of experience, and you saw someone who has tremendous experience already, extremely versatile, unfortunately does require a thoracotomy at this stage. And there's many ways you can put it. The problem with this is it's sort of jerry-rigged, and what Thoratec needs to do is spend more time on their cannulas. Because there's no question, this pump, yeah, it's a great pump. It's pretty expensive, but it's a great pump. But we need cannulas because we've had problems with clot forming around these cannulas. They're not stable and all sorts of things. So I think we need a lot more research in cannula development, and I don't think Thoratec is into that right now. The largest series is out of Columbia. This is their work that's recently published in Circulation. And you can see all comers, 143 patients. And again, 50% 1-year survival, pretty good. And you see this is both to recovery, to transplant, and to other VADs. If one looks at more deeply, what are the risk factors for failure here in a multivariate analysis? The older your age, you're going to be unlikely to live. If you're on dialysis of any sort, if you develop dialysis, those patients do poorly. And the worst group, not surprisingly, is post-cardiotomy failure, and it was about 25% survival with ecentromag. The best group with acute fulminant myocarditis, which recovers just like our young lady did. Let's move on to ECMO. So patients would present with profound cardiogenic shock, not making urine, not oxygenated, etc. Unresponsive to conventional CPR. That is an indication for ECMO because it's percutaneous and can be done on site. We have the luxury at Hospital University of Pennsylvania where we have our perfusionists in the hospital 24/7, as well as my fellows are in the hospital, or somebody's in the hospital 24/7 that can place this in any place in the hospital, ER, cath lab, our own unit, or on the floor. It's an effective triage, as I've already said. If intrinsic recovery is not possible, it's a great bridge to a VAD. And again, it can, we've had several that have recovered from ECMO for acute situations. Again, another bullet slide. Robust support can provide, I would say, 2 to 3 weeks of support. Some people say longer, especially if you're putting it through the axillary. We actually put it through our groin. Very, very cost effective in the United States. Again, we use percutaneous ECMO almost all the time, not central, though I do agree central is more robust. But again, if someone's undergoing CPR, the last thing I want to do is do a sternotomy on them, since most than half are going to not make it. Again, standard Seldinger techniques, long venous cannula, short aortic cannula. I might disagree a little bit about your explanation on why the LV doesn't empty. What is done 100% of the time is ipsilateral limb perfusion. We used to cut down on all these groins. We now, at least my fellows, are pretty good with ultrasound and placing it. But even with that, we get imaging because it's very easy to have this misplaced down a profunda versus the SFA and end up still with a ischemic leg. But 100% of the patients get ipsilateral lung perfusion, and that's sort of a typical scenario. It really minimizes bleeding. Again, robust flows. Again, what we'll do, the right patient, again, not every patient has to die on ECMO, but the right patient who's young enough and doesn't have a lot of comorbidities, some CPR to ECMO, and then we take a breath, and then we say, okay, what should we do? What's right for this family or in this patient? If they have terminal cancer, no one knew it, we withdraw. Hopefully we know that ahead of time. We can, very often in the right patient that can't be VADed easily, you can go right to heart transplant if you can get the heart recovery, but very often to VAD support, either for DT or transplantation. I do want to spend time, which was always mentioned, ECMO is the worst support for getting the LV better unless you it does not unload the LV. The greatness about central ECMO, which frankly still doesn't unload the LV, is that there's multiple options to easily vent the left ventricle, either through the apex or right superior pulmonary vein. We, with peripheral, will favor a mini right thoracotomy and just put a small vent into the left atrium, advance it across the mitral valve, or through the left thoracotomy through the apex. Some centers, we're not, because it gets real expensive, using the Impella now as the vent for the LV with peripheral ECMO. It does work for that. And atrial septostomy was already mentioned. We currently have a lot of ECMO. It would be very unusual to come to Penn and not see anywhere between 2 and 5 people on ECMO, believe it or not. Veno or AV. This talk is about AV. Again, we talked about the Quadrox oxygenator and the McKay, which has really lowered our price from about $18,000 to maybe $2,000 and a few $100s for the Quadrox. Our bedside nurses now take care of ECMO. So the personnel expense is no more than our normal ICU. And we have our perfusionists that, again, can do quality rounds. But again, we've trained our bedside nurses to do it. A lot of contraindications. If the patient's already in multi-system organ failure, you have to wonder, severe sepsis. Watch out for aortic insufficiency. You put someone on ECMO and they have AI, the ventricle will blow up. So you can't really do that unless, and that would be a reason to go to do something different in an LVAD or some central decompression. They have to be anticoagulated. Severe peripheral vascular disease is a disaster, at least the way we're doing it. You'd have to go central, and anything that would limit their expectancy. Once you start doing ECMO on patients that are 70 and older, the results have not been very good. All sorts of complications, high-intensive unit has to take care of this, but everything is possible. Some large studies, this is out of Lancet, already old, showing for acute cardiopulmonary collapse versus balloon. There is now, propensity-matched evidence of superiority of ECMO over balloon pump, not surprising, but also interesting how quickly this 30-minute comes up, where the results start decreasing dramatically if the CPR is ongoing more than 30 minutes. Unwitnessed arrests in the ER, I shy away from. If they arrest in the ER, we're more apt to do it, but unwitnessed arrests in the ER, I probably don't think that's indicated. Again, work out of Pittsburgh showing how often ECMO is used as a bridge for revascularization, and that has worked well. Rather than doing your CABG and coming off on ECMO, I would prefer doing the ECMO, stabilize the patient with acute cardiogenic shock, and then do a PCI often, not so much a CABG. And again, as a bridge to VAD. This is interesting how, this is the ELSO registry of 2013. I believe this is a worldwide registry, and it shows how ECMO use has skyrocketed in the last couple years. Also gives you, again, in this registry, which is obviously biased, what the survival is. And cardiogenic shock, about 33% of your patients will live. Your best, of course, is in your myocarditis. The worst, at least in my hands, is post-cardiotomy failure, which frankly at Penn is barely 20% as far as leaving the hospital. Let me give you some of our data here. This is all ECMO. Again, I'll update it a little bit. 214 patients at Penn in those years, in those 5 years. A majority were AV ECMO. I can tell you in the last couple years we're doing more and more veno ECMO, especially with the flu and H1N1 and other types of pulmonary collapses. And we actually have now a lung rescue team that goes out to the community to place veno ECMO. That's a lot easier than AV ECMO. And you see our bridge experience is not bad, 26 patients. 60% of our patients that have ECMO at Penn historically are having CPR. Either you had CPR, they got back for a second, they're doing CPR, or actually are placing the cannulas as they're undergoing CPR. So it's a high-risk patient population. And how our growth has it's grown. Again, it's ease, it's inexpensive, and it's a great triage. In 2014, which is incomplete here, we're doing about 80 ECMOs a year right now. All different reasons why. Under cardiac and the post-cardiotomy, you can see some brave souls have done it from a type A repair. They have died. Again, pretty good experience with open heart transplantation that could not come off. Again, 80% that the heart will eventually recover, and assorted others. And again, in pulmonary, it's not infrequently now. We're using it for primary graft dysfunction after transplant. 80% successful recovering the lungs. And what Bermudez has done at Pittsburgh is actually has using ECMO, VV ECMO as a bridge to lung transplant. He's done 70, which we have not done at Penn. Just gives you an idea of our ECMO, AV ECMO experience and various pie chart. And frankly, not great results, but this is the truth. and how age dependent it is. In young people, we can expect about a 30% survival, long-term survival, but as you get older, the survival decreases to less than 20%. A very nice experience, I think, is a bridge to bridge with 60% surviving either with a LVAD or a heart transplant. Again, these are patients mostly undergoing CPR. So when you put all these things together, you need something. If you're going to get someone back from true profound shock, you need 5 or 6 liters. I mean, that's the bottom line. And if you don't have that, then they should be used for other things. Maybe before you have shock is helping come off the heart-lung machine, but certainly not for shock. This is the CentroMag experience in green. RV support, ECMO is an excellent RV supporter. Again, I think the Impella device and the tandem that's coming with the RV are very, very interesting. Obviously, ECMO is the only thing with pulmonary support, and you can nicely put either use ECMO as we described, or an RVAD with an ECMO with an oxygenator is a wonderful thing for a right ventricle that still needs support, and you don't need to worry about the left ventricle. Bedside implantation, really only ECMO, and duration of support shown there. So in summary, I think short-term cardiac support is increasingly being used as a bridge to decision, and I think that our patients deserve that, frankly, that we shouldn't give up, and if we can save 30% of them, we should do it. The use of short-term cardiac support should be directed, obviously, by an experienced team, capable of defining correct destination alternatives, but also with the experience to identify futility. There's going to be a lot of complications. You have to be able to be ready for that and be ready for what's the next step. If you can't answer what the next step is, don't put it in the first place. And then myocardial recovery should be aggressively pursued with active unloading as needed. Thank you.